विश यू अल द बेस्ट है त किनभने अहिले जुन CE MDMS क्लास जुन छ त्यो चाहिँ जुन एक्जाम प्याटर्न छ त्यो अनुसारले चाहिँ इट्स गेटिङ मोर टफर डे बाई डे सो अलिकति तपाईँहरूलाई गाइडेन्स होस् भनेर चाहिँ हामीले चाहिँ वी हेभ स्टार्ट दिस क्लास अनि यो क्लासमा चाहिँ तपाईँहरूको टप इन्डियन प्रोफेसरहरू जस्तो तपाईँको प्रेप ल्याडर छ है त त्यसपछि अनएकाडेमीमा पढाउनुहुन्छ उहाँहरूले पनि तपाईँहरूको क्लास लिनुहुन्छ अनि त्यसपछि नेपालबाट पनि जो चाहिँ टपर हुनुहुन्छ योपालि एक्जाममा तपाईँहरूले देख्नु भएको छ जुन टपर हुनुहुन्छ उहाँले पनि तपाईँहरूले दे विल गाइड यु थ्रु दिस एक्जाम है त सो दिस क्लास विल बी बेसिकली अफ 5 months ड्युरेसन है त 5 months ड्युरेसनको हुन्छ अनि यसमा चाहिँ 500 hours इट विल बी मोर देन इभन अब तपाईँको एक्ज्याक्टली भन्नुपर्दा चाहिँ 500 hours भन्दा पनि बढी हुन्छ होला अनि त्यसपछि द्याट विल बी टोटली फोकस्ड अन द करेन्ट CE सिलेबस है त अनि त्यसपछि तपाईँहरूलाई दे हेभ यु हेभ अ लिनियन्सी तपाईँ यु क्यान आइदर टेक अनलाइन क्लास अर यु क्यान टेक फिजिकल क्लास डाइरेक्टली है त त्यसपछि तपाईँहरूले जुन सिलेबस हेर्नु भएको छ नि होइन सिलेबसमा तपाईँहरूले आई थिङ्क यु हेभ सिन द सिलेबस अनुसारले जस्तो मेडिसिनमा इट्स लाइक द वे जसरी मार्क्स एलोकेट भएको छ त्यही अनुसार हामीले नै यो आवर्स पनि एलोकेट गरेका छौँ है त मेडिसिन्स विल बी लाइक फर 72 hours है त अनि किनभने मार्क्स चाहिँ 18 छ कि बिकज इट्स वान अफ द इम्पोर्टेन्ट सब्जेक्ट त्यही भएर हामीले मेडिसिनलाई चाहिँ वी हेभ गिभन 72 hours सर्जरीलाई चाहिँ हामीले वी हेभ गिभन 54 hours है यो चाहिँ टेन्टेटिभ मात्र हो है तपाईँहरूले फेरि यस्तो नसोच्नु होला कि यति नै हो भन्ने चाहिँ छैन इट्स जस्ट अ टेन्टेटिभ आवर्स सो यसरी हामीले प्लान गरेको छौँ दिस जस्ट अ प्लानिङ है त जस्ट फर द ओरिएन्टेसन तपाईँहरूको लागि भनेको अनि अप्स गाइनी अप्सको लागि चाहिँ हामीले 30 hours मेन्टेन दिएका छौँ पेडाइटिसको लागि चाहिँ 24 hours छ अनि प्याथोलोजीको लागि 24 hours छ अर्थोपेडिक्सको लागि पनि 20 hours छ अनि ENT को लागि 18 hours छ है अनि त्यस एनेस्थेसियाको लागि 14 hours छ डर्माको लागि चाहिँ 14 hours छ अप्थाल्मोलोजीको लागि 14 hours छ साइकेट्रीको लागि 14 hours छ फरेन्सिक मेडिसिनको लागि 12 hours छ अनि जति पनि हाम्रो CPD टपिक छ नि यो एथिक्सहरूको कुरा छ त्यसको लागि 12 hours छ रेडियोलोजीलाई 10 hours छ त्यसपछि कम्युनिटी मेडिसिनको लागि हाम्रो 20 hours छ फिजियोलोजीलाई 24 hours छ एनाटोमीको लागि 24 hours छ त्यसपछि माइक्रोबायोलोजीको लागि 20 hours छ फार्माकोलोजीको लागि 20 hours छ र बायोकेमिस्ट्रीको लागि तपाईँको 20 hours छ है त सो जसरी तपाईँको ऊ भएको छ सेड्युल भएको छ त्यही अनुसार नै हामीले त्यो जुन मार्क्स एलोकेट भएको छ त्यही अनुसारले हामीले आवर्स पनि एलोकेट गरेका छौँ अनि अर्को एकदम इम्पोर्टेन्ट कुरा चाहिँ तपाईँहरूलाई के भन्न चाहन्छु हामीले एउटा पहिलेदेखि नै देखिरहेको कुरा सब्जेक्ट एक्सपर्ट जो जति पनि सब्जेक्ट छ तपाईँहरूको जति पनि सब्जेक्टहरू छ इच एन्ड एभ्री सब्जेक्ट विल बी टेकन बाई द सब्जेक्ट जस्तो तपाईँको सर्जरीको क्लास तपाईँको त्यही अनुसार लिनुहुनेछ हाम्रो फ्याकल्टी मेम्बर सर्जरीको फ्याकल्टी लिनुहुनेछ माइक्रोबायोलोजीको फ्याकल्टी लिनुहुनेछ फार्माको जुन फ्याकल्टी हुनुहुन्छ उहाँले लिनुहुनेछ सो दिस इज एन एरा अफ स्पेसलाइजेसन सो यो स्पेसलाइजेसनको एरामा चाहिँ इच एन्ड एभ्री सब्जेक्ट विल बी टेकन बाई द सब्जेक्ट एक्सपर्ट सो तपाईँहरूलाई इन डेप्थ किनभने CE को तपाईँहरूको एक्जामको क्वेसनहरू हेर्दा चाहिँ इन डेप्थ क्वेसनहरू सोधेको कारणले गर्दा चाहिँ हाम्रो चाहिँ एउटै मान्छेले चाहिँ सबै कुरा पढाउन सक्छ त्यसको इन डेप्थ नलेज हुन्छ भन्ने चाहिँ हामीलाई विश्वास लाग्दैन सो वी बिलिभ इन स्पेसलाइज नलेज सो इच एन्ड एभ्री सब्जेक्ट विल बी टेकन बाई द सब्जेक्ट एक्सपर्ट है त नाउ विदाउट टेकिङ मच योर टाइम है त नाउ आई विल बी ह्यान्डिङ ओभर टु द डाक्टर राजेश गुब्बा त्यसपछि उहाँले लिनुहुन्छ है त ओके सर यु क्यान टेक द क्लास सर होइन हि इज अ भेरी रिनाउन्ड प्रोफेसर वेल नोन टु द एभ्रीबडी सायद तपाईँहरूलाई सबैलाई थाहा नै छ है त तपाईँले युट्युबमा भिडियो पनि हेर्नु भएको छ होला डाक्टर राजेश गुब्बाको है त he has taken classes for many platforms and he is a very well known professor so hand over to you sir.
Yes, thank you very much Dr. Anil for the introduction and definitely I'm very happy to be the part of the Paradise Institute and yes, and I welcome you all the students for this the introductory class. So now I am Dr. Rajesh Gubba. I am the general medicine educator. So I'll be taking the general medicine part of your the competitive entrance exam. So today I will take up one important topic in the endocrinology. Okay. Now in the endocrinology, so the topic which I'll be taking up is mainly the topic related to the pituitary disorders, right? So yes. So the topic is the endocrinology. Now, in the endocrinology, if you take the master of the endocrine orchestra, so can anyone tell me what is the organ which is considered as the master of the endocrine orchestra? Yes, so I want you to be actively participating in the session. Yes, what is the organ which is considered as the master of the endocrine orchestra? Anyone? I want participation from your side. Yes, no one want to answer and no one want to talk. You can text also. You can just text in the chat box also. Like, yeah, very good, Sandeep Kar. So the master of the endocrine orchestra, that is your pituitary gland. So pituitary gland, what is another name for the pituitary gland? Any one of you, please? Yes, what is another name for the pituitary gland? Any one of you, please? Yes, Sandeep, can you tell me what is another name for the pituitary gland? So, the another name for the pituitary gland, it is the hypophysis cerebri. Right? It is called as hypophysis cerebri. Now, if you take this pituitary gland, we have the anatomical division of the pituitary gland. So, how is this anatomical division of the pituitary gland is? The pituitary gland, it is anatomically divided into the two structures. One is anterior pituitary and the other one is the posterior pituitary. Now this pituitary gland, it is under the control of, yes, any one of you please? The pituitary gland, it is again under the control of which particular organ? Anyone? Yes, very good Aditi. So it is under the control of the hypothalamus. So hypothalamus is the one which will try to regulate the hormones which are being produced from the pituitary gland. Now this hypothalamus and pituitary gland, both of them, they are connected by a structure. And what is this particular structure? This is called as infundibulum. Right? This is called as infundibulum. Right? Now, also the another name for this is, it is also called as hypothalamo because it is connecting the hypothalamus. So hypothalamo hypophyseal tract, right? Hypothalamo hypophyseal tract. This is another name for the connection because it is connecting the hypothalamus and hypophysis cerebri. That is the reason why it is called hypothalamo hypophyseal tract. Okay. Now you take the anterior pituitary hormones. Anterior pituitary, it produces certain hormones. Yeah. Yes. Again, basic question. See, like we will try to discuss little basics for at least 10 or 15 minutes. Then I will move on to a particular endocrine disorder. Yeah. So please tell me what are the various hormones in anterior pituitary? Yes. Anyone? What are the various hormones which are being produced from the anterior pituitary? Very good, Sandeep. One is your growth hormone. Excellent. Next. Yeah, excellent. So growth hormone, TSH, LH, FSH, or so you people said 4 hormones. Totally, there are like 7 hormones from the anterior pituitary. Very good, Rupam and Aditi. So ACTH also. Next, 2 more hormones. So I'll just give you a mnemonic for this. The hormones from the anterior pituitary are, you can just remember this mnemonic, that is gap left. Okay. So gap left is the mnemonic for the hormones from the anterior pituitary. Yeah, very good, Aditi. You have added prolactin. One more. Okay, now I'll try to tell you that. So gap left, please remember that. So you can just remember like this, okay? So a gap is left in my heart after you left me, right? So that is a mnemonic that you can remember, all right? So G stands for growth hormone. A stands for ACTH, P is the prolactin, L stands for luteinizing hormone, F is follicle stimulating hormone, T is thyroid stimulating hormone. Can anyone tell me what is E? Can anyone tell me what is E? Yes, I'm waiting for your answers. Yes, anyone want to guess what exactly is the E from antidepressant? No, 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 not estrogen. Estrogen is from the ovaries, right? Estrogen is from the ovaries. Yeah. Yes. Any other attempt? Not estrogen. Not estrogen. Okay. So E stands for endorphins. E stands for endorphins. Okay, so these are the hormones from the anterior pituitary: growth hormone, ACTH, prolactin, luteinizing hormone, endorphins, LH, and as well as the FSH. Now, you take the posterior pituitary hormones, right? The posterior pituitary, please tell me what are the hormones synthesized in the posterior pituitary? Please tell me what are the hormones which are synthesized in the posterior pituitary. Anyone? Okay, antidiuretic hormone and oxytocin. Okay, this is the biggest mistake by many of the students. This is biggest mistake by many of the students, that posterior pituitary does not synthesize the hormones, right? Posterior pituitary does not synthesize the hormones. Okay, posterior pituitary will only act as the storage organ, right? Will only act as the storage organ for oxytocin and as well as vasopressin, which is nothing but antidiuretic hormone. But where are these hormones synthesized then? Yes, where are these two hormones synthesized? Oxytocin and vasopressin, where are they synthesized? Very good, Aditi, excellent. So they are synthesized in hypothalamus, right? They are synthesized in the hypothalamus. Okay, now the next important point is the secretion of all these hormones. They are under the control of hypothalamus. Anterior pituitary hormones, whatever are being secreted, they are under the control of the hypothalamus, right? Now, okay, I'll just ask you one quick, I'll just give you a clinical scenario. I'll give you a clinical scenario. We have one 23-year male patient. Okay, so let us just assume he has finished his postgraduate entrance exam, right? So he has finished his postgraduate entrance exam. Okay, and in the exam he has topped, right? So he is the topper of that PG entrance exam, right? Now his father has gifted him a racing bike because that 23-year male was very much interested in the racing bike. So the father has gifted him the racing bike, and this 23-year male, now he is very much interested on the racing bike, so he went for a ride, right? And he accelerated the speed up to 120, 130, 140, even 150 also. But unfortunately, he had a road traffic accident, right? And after this road traffic accident, he was like unconscious, right? He was unconscious after this road traffic accident, right? Now he was brought to the emergency department. In the emergency department, CT brain was done on an emergency basis, right? CT brain was done on an emergency basis. Now, when CT brain was done, the CT brain showed the presence of bleed in hypothalamus, right? The CT brain showed the presence of bleed in the hypothalamus. Okay. Now, what is the question? This is a clinical scenario. Had a road traffic accident, head injury, CT brain done, showing the bleed in the hypothalamus. The question is, which of the following hormones does not decrease in this patient, right? In this patient, which of the following hormones does not decrease? The options are growth hormone, second option luteinizing hormone, third option prolactin, fourth option ACTH. Yeah, please answer. Which hormone does not decrease in this patient? I'm waiting for your answer. Very good, Rupam, and as well as Peter. Excellent. Why, Rupam? Why prolactin does not decrease? Whatever you have said is correct. Yes, yes, Peter. Why prolactin does not decrease? What you have said is correct. The prolactin does not decrease in this particular patient. But why do you think that the prolactin does not decrease in this patient? Yes. Okay, right. Whatever you have said is correct. I'm very happy that you have done the proper analysis. But let me just tell you why prolactin does not decrease. Why other hormones are decreasing, but why prolactin is not decreasing? Because prolactin is also an anterior pituitary hormone. And whatever I've said, like growth hormone, ACTH, and as well as the LH, all of these are the anterior pituitary hormones. They will decrease, but the prolactin will not decrease. Why? Why? Because for the release of these hormones, where should be the stimulus coming from? The stimulus should be coming from the hypothalamus. That is for the release of the growth hormone. Okay, growth hormone releasing hormone should act on anterior pituitary, then growth hormone from anterior pituitary will produce, right? So all these are hypothalamic hormones, right? Now you take ACTH. What is required for the production of ACTH? What is required for the production of the ACTH? Any one of you? What is required for the production of ACTH from the anterior pituitary? Or what is required from hypothalamus? Very good, Aditi and as well as Rupam. And yes, Paudal, you're right. That is cortisol releasing hormone. And for the release of LH and FSH, you require GnRH, gonadotrophin releasing hormone. Now, can anyone tell me what about prolactin? Can anyone tell me what about the prolactin? The prolactin production is under the regulation of, very good, Aditi, I'm very happy. So that is the dopamine. Okay, so dopamine, yes, Rupam, tell me now, dopamine will inhibit the prolactin production or stimulate the prolactin production? Dopamine will inhibit the prolactin production or will stimulate the prolactin production? What do you say? Anyone? Yes, very good, Maharajan, and as well as Aditi. So dopamine will inhibit the prolactin production. Where is the dopamine coming from? Hypothalamus. Whereas the remaining hormones, if you take growth hormone releasing hormone, will stimulate the growth hormone production. Cortisol releasing hormone will stimulate the ACTH production. Gonadotrophin releasing hormone will stimulate the LH and as well as FSH production. And the TSH production is by the TRH, which is coming from hypothalamus, which is nothing but your thyroid releasing hormone. Whereas you take endorphins. For the production of endorphins, you don't require any hormone which is coming from hypothalamus. For the production of endorphin, what is required is like exercise, right? Or when the individual is in a state of pain, the endorphins will be released and the endorphins will reduce the pain within the individual. So this is a basic physiology of the pituitary gland, right? Anterior pituitary, the hormones are gap left, and the production of this gap left is under the control of hypothalamus, except for your prolactin. Prolactin production is inhibited by dopamine, which is coming from the hypothalamus. So the point is, the point you should understand is dopamine is considered as prolactin inhibitory hormone. Right? Prolactin inhibitory hormone. Okay, so that is the dopamine, right? Now, next is if dopamine does not act, right? If dopamine does not act on anterior pituitary, then there will be release of prolactin from anterior pituitary. Okay, that is the concept of the dopamine and as well as prolactin connection. I mean the regulation, right, or relation. So this is about the basic introduction to the pituitary and as well as hypothalamus. Now what we will do is we will take up one important hormone in this anterior pituitary and we will try to discuss its abnormality. Okay, we will try to discuss the abnormality related to prolactin itself. We'll try to discuss the abnormality related to prolactin. So now prolactin, if you see the basic physiology of the prolactin, if you observe, what is the normal levels of the prolactin? Normal levels of the prolactin in our body, it is 5 to 20 micrograms per deciliter, right? 5 to 20 micrograms per deciliter. That is the normal levels of the prolactin. Now, we have a clinical abnormality called hyperprolactinemia, right? You have an abnormality called hyperprolactinemia. That means where the prolactin levels are increased. Now, but before going on to the hyperprolactinemia, you should know the basic physiology of the prolactin. Okay. Now, I will just discuss the basic physiology of the prolactin. Then I will discuss about the abnormality related to prolactin, that is hyperprolactinemia or prolactinoma. What is that abnormality? You see, what is the effect of the prolactin in females and effect of prolactin in males? Yeah, can anyone answer? What is the role of prolactin in females? What is the role of prolactin in females? Anyone? Yeah, very good, Aditi. So in females, it will cause lactation. Next. What is the effect of prolactin on the female sex hormones? Yeah, so uh, prolactin will inhibit the estrogen production and prolactin will also inhibit the progesterone production. Okay, will inhibit the estrogen and as well as the progesterone. Okay, right? And it is just required for the lactation. Yeah, definitely. Yes, Rupam, you're right. See, it is required for the lactation means obviously it is required for the development of the mammary gland as well, right? Now, you take in males. What is the effect of prolactin in males? Yes. What is the effect of prolactin in males? Anyone? Anyone quickly? What is the effect of prolactin in males? Basic physiology. Gynecomastia, na? Okay, fine. So, what the prolactin does if it is produced in excess quantity in males is that in males, it will inhibit the testosterone synthesis. Right? It will inhibit the testosterone synthesis. And prolactin will also inhibit spermatogenesis. Right? Will also inhibit spermatogenesis. That is the effect of prolactin in males. And in females, it will cause lactation, inhibition of estrogen and progesterone. So this is the basic physiology of the prolactin. Now, we will try to discuss in hyperprolactinemia what will happen. Right? Hyperprolactinemia, what will happen? Okay, right. So, first of all, what are the conditions where you will have the hyperprolactinemia? What are the conditions where you will have hyperprolactinemia? There are certain physiological causes for hyperprolactinemia Then you have pathological causes for hyperprolactinemia, right? Yeah. So please tell me physiological causes. Pathological causes, I will tell you. Pathological causes, I will tell you. Tell me physiological causes of hyperprolactinemia. Physiological causes for hyperprolactinemia. Anyone? This you should be able to answer, right? What are the physiological causes for hyperprolactinemia? So Rupam, you should tell it as, yes, Aditi has answered it 1 point, correct, Aditi? That is pregnancy, right? Yes, Rupam. So, so you can tell in lactating mother. So during lactation or lactating mother, then the other physiological causes for hyperprolactinemia will be the prolactin level increases in sleep. And you know that too, in which phase of sleep? That is rapid eye movement of the sleep. That's a multiple choice question. What's the question that can be asked is prolactin level increases during REM, right? And they'll give you as NREM stage 1, 2, 3. This will be the options, right? So during which phase of the sleep the prolactin level increases? That is during the REM phase of the sleep. That is during REM phase of the sleep. Okay? Right. And the prolactin level also increases in stress, right? And the prolactin level also increases in sexual stimulation. What is that sexual stimulation? That is nipple stimulation. So these are the physiological causes for hyperprolactinemia. And you take the pathological causes for hyperprolactinemia. Pathological causes for hyperprolactinemia, it includes the following. We have tumors. Then we have some systemic conditions. Then we have some drugs. Right? Then we have some drugs. Okay. What are the tumors? Right? As Rupam was telling, one is your pituitary tumor. What pituitary tumor is that? That is prolactinoma. So prolactinoma, this is one of the important secretory tumor of the pituitary that will cause excessive prolactin secretion. The other tumors which will produce excess amount of the prolactin is craniopharyngioma. Now, what exactly is craniopharyngioma? How does this craniopharyngioma will cause hyperprolactinemia? I will try to discuss. So craniopharyngioma, it's a tumor which is originating from Rathke's pouch. Right? So it is a craniopharyngioma is a tumor which is originating from Rathke's pouch. Now, what this craniopharyngioma will do? What this craniopharyngioma will do? I'll tell you. Why there is hyperprolactinemia in case of craniopharyngioma? Let me tell you. So, craniopharyngioma, which is originating from Rathke's pouch, you know what does that do? This craniopharyngioma will compress the infundibulum. Okay, this is your craniopharyngioma. This will compress the infundibulum. Once your infundibulum is compressed, what will happen is the dopamine which has to come from hypothalamus, which has to reach the anterior pituitary, it will not reach. The dopamine which has to reach the anterior pituitary does not reach. So thereby what will happen now? Dopamine is not acting on anterior pituitary in case of craniopharyngioma. When dopamine does not act on anterior pituitary, what did we discuss? Right? You see this point here. Okay. So the point here that we discussed is dopamine, if it does not act on anterior pituitary, then the prolactin secretion increases. So you should remember that in case of craniopharyngioma, the tumor is compressing the Rathke's pouch, thereby the dopamine of hypothalamus does not act on anterior pituitary, thereby the prolactin secretion increases, right? Next, what are the systemic causes for hyperprolactinemia? Systemic causes are like cirrhosis of liver, then chronic renal failure, then in patients with primary hypothyroidism, right? Primary hypothyroidism. So these are the systemic causes for the hyperprolactinemia. Let me explain you why. Why in these conditions the prolactin level increases? Why? Because you take in patients with, okay, the prolactin which is released from anterior pituitary, the prolactin which is released from anterior pituitary, this will undergo metabolism in the liver, right? After getting metabolized in the liver, it is excreted through the kidney, right? It is excreted through the kidney. So the point that you need to remember here is, if there is cirrhosis of liver, if there is damage to the liver, what will happen? The prolactin metabolism does not occur and the prolactin level increases. If there is chronic renal failure, right, the prolactin which has to be excreted through the kidney does not get excreted out. Again, the prolactin level increases. Okay, so in cirrhosis and chronic renal failure, the prolactin level increases. Now, coming to primary hypothyroidism. Why, in case of primary hypothyroidism, the prolactin level increases? The reason is that, so in primary hypothyroidism, what is happening? The problem is in the thyroid gland, because of which T3, T4 levels are reduced. Okay, now, can anyone tell me, when T3, T4 is reduced, what will happen to the TRH levels of the hypothalamus? Yes, when T3, T4 levels are reduced, what will happen to TRH, which is coming from the hypothalamus? Anyone? Yes, I'm waiting for your answers. When T3, T4 is reduced in primary hypothyroidism, what will happen to the TRH? This is basic physiology. I'm not asking medicine at all. Very good, Aditi, and yeah, Aditi has answered it correctly. So when T3, T4 is reduced, the TRH level increases. There is increase in the TRH, right? Now, this increased TRH, yes, very good, Acharya. So the TRH level is increased. This increased TRH will not only increase the TSH from anterior pituitary, this increased TRH will also increase the prolactin from the anterior pituitary, and that will result in the hyperprolactinemia. That will result in the hyperprolactinemia. So what are the systemic causes? Cirrhosis of liver, chronic renal failure, and as well as the primary hypothyroidism. So in primary hypothyroidism, the TRH from hypothalamus increases. That will increase the prolactin level. Coming to the drugs. Now, which group of drugs will increase the prolactin level? Okay, can anyone broadly guess and tell me what group of drugs will increase the prolactin? What should be the mechanism of action of those drugs to increase the prolactin? Anyone? Aditi, whatever you have said is correct actually. You said antipsychotics, right? You're absolutely right. But what is the principle in that? What is the principle of the drugs which is increasing the prolactin? Which group of drugs will increase the prolactin? Which group of drugs will increase the prolactin? What is the concept? Yes, very good, Rupam. Excellent. Yes, Rupam and as well as Ananda, you're right. Yeah. So any drug, right? Any drug, please remember, which are dopamine synthesis inhibitors, right? Any drug which is your dopamine synthesis inhibitor, or any drug which is a dopamine receptor blocker, they will increase the dopamine prolactin levels. They will increase the prolactin levels, because if dopamine is acting on anterior pituitary, prolactin will not be released. If dopamine does not act on anterior pituitary, the prolactin will be increased. So any drug which is inhibiting the dopamine synthesis or blocking the dopamine receptors, they will increase the prolactin levels. Now, what are those drugs? So these drugs are, right, as Aditi was saying, that is your antipsychotic drugs. Example, risperidone, then phenothiazines. They will inhibit the dopamine synthesis, right? That is one. Next, metoclopramide. Can anyone tell me what is metoclopramide? Yes. What is metoclopramide? Quickly, what is metoclopramide? Pharmacology. Very good, Aditi. It is an anti-emetic. Yes, Ananda, you're right. It is an anti-emetic. So what this metoclopramide will do? Metoclopramide will block the dopamine receptors. So once the dopamine receptors are blocked, the prolactin level increases because dopamine level is reducing. The other one is cimetidine. What is cimetidine? Yes, what is cimetidine? Any one of you, please. What is cimetidine? Cimetidine is a right. Very good, Aditi. So it is the H2 receptor blocker. Right? It is a H2 blocker, which is used in the treatment of peptic ulcer. No. It is not proton pump inhibitor. Ananda, it is not proton pump inhibitor. Proton pump inhibitors are Zols, that is pantoprazole, lansoprazole, right? That will be your proton pump inhibitors. Your cimetidine is a H2 blocker, which is also used in the treatment of peptic ulcers. But these days, we are not using cimetidine because of its adverse effects, right? Now, the next important, so this is the story of the causes of the hyperprolactinemia. Physiological causes, pathological causes. Physiological causes are pregnancy, lactating mother, sleep, stress, and nipple stimulation. Pathological causes are tumors like prolactinoma and craniopharyngioma, systemic conditions like cirrhosis of liver, chronic renal failure, and primary hypothyroidism. Drugs are the drugs which will inhibit the dopamine synthesis or dopamine receptor blockers. Okay. Now, followed by that, we will try to take up the discussion in detail about the prolactinoma. Right? Prolactinoma, it's a very important part of the discussion in the endocrinology. So, if you take this prolactinoma, right, it is a tumor which is originating from lactotroph cells of the pituitary gland. Tumor which is originating from lactotroph cells of the pituitary gland, right? And this prolactinoma, it is the most common secretory tumor of the pituitary. Right? It is the most common secretory tumor of the pituitary. And this prolactinoma, it is more commonly observed in females rather than males. And this prolactinoma, it is commonly observed in age group of around, right, commonly observed in age group around 20 to 30 years, right? And this prolactinoma, depending upon the size, we have two sizes. One is your microadenoma, right? And the other one is macroadenoma. Right? So we have micro and as well as the macroadenoma, right? Now, what is the difference between these two in sizes are microadenoma means the size of the tumor is less than 10 mm. Macroadenoma means the size of the tumor is more than 10 mm, right? Between these two, which is more common in case of prolactinoma? In case of prolactinoma, the more common is the microadenoma than compared to that of the macroadenoma, right? Now, the point here you should understand is what will be the difference between these two clinically? What will be the difference between these two clinically? Okay, first of all, so it's a tumor which is originating from the pituitary gland. Can anyone tell me Anatomically, where is the pituitary gland present? Anatomically, where is the pituitary gland being present? Yes. What is the anatomical location of? Very good, Mukesh. Excellent. So it is present in the sella turcica of sphenoid bone. It is present in the sella turcica of the sphenoid bone. Now, what is the difference between these two is both of them commonly the clinical features will be endocrine manifestations. Okay, so endocrine manifestations are common in both, right? Endocrine manifestations are common in both, whereas the additional features that you will have in macroadenoma will be mass effect on the surrounding structures. Right, mass effect on the surrounding structures. Okay, so that is about the additional things in macroadenoma. Okay, now first let us take up the discussion of the endocrine manifestations. What will be there in micro or the macroadenoma? So if you take the endocrine manifestations, okay, now let us just discuss clinical features. Clinical features in prolactinoma, out of which what I am discussing now, I am discussing endocrine abnormality in case of prolactinoma. So what will be the endocrine manifestation in, right, endocrine manifestations in males, and what will be the endocrine manifestations in females? Yes, any one of you? I have already said you the basic physiology. I have already said you the basic physiology. Okay, now tell me what will be the endocrine manifestations in males? Yes, please answer. What will be the endocrine manifestations in males? I want you to apply the knowledge of the physiology what we have discussed. Yes, I said you the basic physiology of the prolactin in males is it will inhibit the testosterone and it will inhibit the spermatogenesis. Very good, excellent. That is what is nothing but the application of the physiology in medicine, right? Yes, Rupam, Aditi, Mukesh, right? Very good. So in males, the testosterone is not produced now. So there will be loss of libido, right? So there will be decreased sexual desire. That is one point. Next, spermatogenesis does not occur. That will result in infertility. That will result in infertility. Okay. Now, please tell me what will be the effect in males, sorry, females. What will be the effect in females now? Right. Very good, Mukesh. So they will have galacturia, right? And they will have amenorrhea because estrogen and progesterone is not produced. What about fertility? What about fertility, Mukesh? Yes, Rupam. What will happen to the fertility? Right. So there will be infertility even in these individuals also because your estrogen and progesterone is not there. So ovulation does not occur. When ovulation does not occur, and that will result in the infertility. Okay. So this will be the endocrine clinical manifestations in males and females in case of the prolactinoma. Now, you take the mass effect, right? So if you see the mass effect in patients with the macroadenoma, now, so mass effect will be there only in the macroadenoma only, right? Mass effect will be there only in the macroadenoma. Now, what will be that mass effect? That is the mass effect over the surrounding structures. Where is your pituitary gland present? Just now, as you people were, as Mukesh was telling, the pituitary gland is present in sella turcica. Now, what is that important structure which is adjacent to your pituitary gland? Because whenever there is macroadenoma, that will cause the compression on the surrounding structures. So what is that structure which is very near to the pituitary gland? Anyone? Excellent, Prajwal. That is the optic chiasma. You see this here. I show you the image of the pituitary gland. So pituitary gland, which is present in the sella turcica, yeah. So this is the pituitary gland. So this is the pituitary gland. This pituitary gland is in close connection with the optic chiasma. This is the optic chiasma. So optic chiasma is what it is, the crossing of the optic nerves. So whenever the pituitary increases in size, it causes compression of the optic chiasma, and that will result in the visual abnormalities. So what will be that visual abnormalities? Right. So what will be the visual abnormalities? So in case of mass effect, yeah, very good, Ella Powdle. But in early stages, right, in early stages, they will have bitemporal, right, bitemporal superior quadrantanopia, right, bitemporal superior quadrantanopia. Now, what do you understand by this word bitemporal superior quadrantanopia? It means that this is the visual field, right, and this is the nasal half of the visual field, and this is the temporal half of the visual field, right? Now, in this, right, in this, which particular component of the vision is lost? This component. Okay, so this will be bitemporal superior quadrantanopia. That is what is observed initially. Later, right, in the later stages, Ramya. So in the later stages, there will be Ramya, bitemporal hemianopia. Right, so bitemporal hemianopia in the sense the temporal half of the vision is being lost. The temporal half of the vision is being lost. Okay. Now, both of you have said bitemporal hemianopia, right? Mukesh and as well as the Ila Paudel. But can you people tell me why temporal half of the vision is being lost? Why not the nasal part of the vision? What you have said is correct actually. Mukesh and as well as Ila Paudel, what you have said is correct. But why temporal half of the vision is lost? Why not the nasal half of the vision being lost? Very good, Aditi. So, okay, the nasal fibers are crossed, but what you have to say is the macroadenoma, it compresses, right? It will compress the nasal fibers, which are crossing. Okay, so nasal fibers are what? Nasal fibers are the one which will bring the vision from the temporal half of the visual field. So, as the nasal fibers are compressed by the macroadenoma, that is the reason why temporal vision is being lost on both the sides. And once there is macroadenoma, there will be raised intracranial pressure. And because of the raised intracranial pressure, they will have headache. Because of raised intracranial pressure, they will have headache. So that will be the additional features that you will have in macroadenoma. So remember now, in microadenoma and macroadenoma, you will have endocrine manifestations. Whereas in macroadenoma, you will have the mass effect on the surrounding structures. That will be in the form of the bitemporal hemianopia. So that is about the clinical manifestations. Now, how is that you will do the workup? Workup in case of the prolactinoma. What is the investigation of choice? The investigation of choice will be estimation of serum prolactin levels, right? Estimation of the serum prolactin levels. That is the investigation of choice. And that too, when we should do this serum prolactin levels, the serum prolactin levels, this should be done early morning fasting state, right? Early morning fasting state. That is when you need to estimate the serum prolactin levels. What is the normal value we have discussed? 5 to 20 micrograms per deciliter. That is a normal value, right? Now, when will you call it as prolactinoma? When will you call it as the prolactinoma? If the values of serum prolactin is more than 200, then we call it as prolactinoma. If the value, if it is in between 100 to 200 micrograms per deciliter, this is strongly suggestive of the prolactinoma. Right? Strongly suggestive of the prolactinoma. That is if the levels are in between 100 to 200. And if the levels are less than 100, this might be due to any other cause causing hyperprolactinemia except prolactinoma. Right? Except the prolactinoma. Okay. So this is about how do you work up. That is your estimation of the serum prolactin levels. Then once you find the levels are more than 200, once you find the levels are more than 200, then you need to do MRI of the pituitary. Why is that you need to do MRI of the pituitary? You need to do MRI of the pituitary because to differentiate whether the tumor which is present, whether it is microadenoma or macroadenoma, to differentiate these two, we need to do this, the MRI of the pituitary, right? And so this is about your workup story. This is about your workup. Now, the next important thing you need to know is, right? Next important thing you need to know is how do you treat these patients? Treatment. So, if you see the treatment of the prolactinoma, first line treatment is what are the drugs which are inhibiting the prolactin? Dopamine. So, you should give dopamine agonists. Dopamine agonists, they are considered as the drug of choice. Now, what are the examples of the dopamine agonists? The examples of dopamine agonists are bromocriptine, cabergoline, then quinagoline. Okay, these are the examples of the dopamine agonists. That will be the drug of choice, right? Now, you should know which drug to be given in pregnancy, right? Yes, Mukesh, Ila Paudel, and Ananda said like the dopamine agonist examples. But what is the drug that we give in pregnancy? Pregnancy with prolactinoma. What is the drug of choice? Yes, pregnancy with prolactinoma. What will be the drug of choice? So, in pregnancy, the drug that we give is bromocriptine, right? Whereas non-pregnant individuals, you need to give cabergoline. Non-pregnant individuals, you need to give cabergoline. Okay, right. And another example is quinagoline. Now, if suppose if the patient is refractory to medical management, now when do you tell that the individual is refractory to medical management, that is, if the patient, if prolactin is not reducing, if the prolactin level is not reducing, or if the size of the tumor is not reducing, that is what you mean by the word refractory. And when the individual is refractory to medical management, then you need to do or surgical resection. And what is that surgical resection? That is transsphenoidal pituitary adenectomy. Right? You need to do transsphenoidal pituitary adenectomy, which is nothing but surgical resection. But when will you do this? You have to do this whenever there is like refractoriness to your medical management. The patient is not responding to the medical management, then you need to do this transsphenoidal pituitary adenectomy. Or if suppose, if the patient is having, right, if the patient is having dopamine agonist intolerance, right, the patient is having dopamine agonist intolerance, then also you need to do, just 1 minute. Okay. Right. So when the individual is having dopamine agonist intolerance, then also you need to do transsphenoidal pituitary adenectomy. So this is about your prolactinoma. This is about your prolactinoma. Okay. So we will do some quick questions on the same topic of the prolactinoma, right? And we'll do the quick recap also. Okay. First of all, let me do a quick revision. So please tell me, what is the hormone which is under the inhibitory control of the hypothalamus? I want everyone to actively participate. I want everyone to actively participate. What is the hormone which is under the inhibitory control of the hypothalamus? Yes. What is the hormone which is under the inhibitory control of the hypothalamus? No, no, no. Dopamine is the inhibitory hormone, but which hormone is under the inhibitory control of the hypothalamus? That is your prolactin. Prolactin is under the inhibitory control of the hypothalamus. Okay? Yes. Answer this question. Which among the following is not the anterior pituitary hormone? Yes. Oh, which of the following is not the anterior pituitary hormone? Very good, Ananda. So the answer is the GnRH. GnRH is what? It is the hypothalamic hormone. Right? It is hypothalamic hormone. Right? Now, you see the questions on the prolactin per se. Yeah. Answer this. Which of the following is the most common type of the pituitary adenoma? Most common type of pituitary adenoma. Very good. That will be your prolactinoma. So prolactinoma, it is the most common secretory tumor of the pituitary. It's the most common secretory tumor of the pituitary. Okay. And what are the cells in case of prolactinoma? The cells in prolactinoma is lactotroph type of cells. Lactotroph type of cells. Right. Next. Yeah. Answer this. All of the following are the causes of hyperprolactinemia except. Yeah, very good, Ujala. So the answer is no, Ananda. Why phenothiazines? The answer is bromocriptine. Bromocriptine, in fact, it is used in the treatment of hyperprolactinemia. Whereas phenothiazines, methyl dopa, and as well as metoclopramide, all these drugs will increase the prolactin levels because they are all your dopamine antagonists, right? whereas your bromocriptine is a dopamine agonist. Yes. Yeah. A 30-year-old woman presented with secondary amenorrhea for 3 years along with galacturia. The most likely cause of her symptoms would be right. So the most likely cause of her symptoms would be the prolactinoma, because secondary amenorrhea, that is endocrine manifestations, galacturia, that is also an endocrine manifestation, right? Next. We have a 35-year-old female presented with 1-year history of menstrual irregularity and galacturia. She has on and off headache. Her examination revealed bitemporal superior quadrant anopia. Fundus examination showed primary optic atrophy. Which of the following is the most likely diagnosis in this case? So again, the answer is pituitary macroadenoma. Now, why is it macroadenoma this time? Because there is like mass effect. Okay, so there is bitemporal superior quadrant anopia, which is nothing but mass effect on the optic chiasma, which is mass effect on optic chiasma. Okay, so that is your pituitary macroadenoma. So in this patient, menstrual irregularity, galacturia is there, which is endocrine manifestation. Bitemporal superior quadrant anopia is there, which is nothing but your mass effect. Okay, now your craniopharyngioma is a differential diagnosis for prolactinoma, right? But this craniopharyngioma, it has, yeah, that's what Aditi, I'm coming to that discussion only. Okay, this craniopharyngioma, it's a differential diagnosis for prolactinoma. But craniopharyngioma, the age of presentation, if you see, bimodal age of presentation. What do you mean by bimodal age of presentation? It is observed in children and it is observed in elderly individuals. Whereas here, if you observe, it's a middle-aged female, right? Prolactinoma is observed in middle-aged female. So age is not matching your craniopharyngioma, right? Yes, Aditi, did you understand this point? Why not craniopharyngioma? Right. Next question. Yeah, please answer this. Investigation of choice of the hyperprolactinemia. Right, it's a direct question, it's not a difficult one at all. So it is prolactin estimation, right? That serum prolactin estimation should be done early morning fasting state. Let me tell you one additional point here. The prolactin levels can get affected by biotin. The levels of the prolactin can get affected by the biotin. So that is the reason why when the patient is on biotin supplements, don't do estimation of the serum prolactin. It will give you a falsely low values. Now, the patient should be off biotin for at least 8 hours. The patient should be off biotin for at least 8 hours. Then you can estimate the serum prolactin levels, right? Next. Yeah. A young woman with secondary amenorrhea and galacturia. MRI shows tumor of less than 10 mm diameter in pituitary fossa. What is a drug of choice or what is a treatment of choice? What is a treatment? Yes. So, like, what is the diagnosis here? The diagnosis is the prolactinoma. So, if the diagnosis is prolactinoma, what is the answer? The answer is bromocriptine. It should be a dopamine agonist. It should be a dopamine agonist, which is nothing but your bromocriptine, right? So this finishes the topic of the prolactinoma, right? So I'll just do a quick recap in 2 minutes of the prolactinoma. So prolactin, it is under the inhibitory control of the hypothalamus by your dopamine, and the physiologically prolactin levels are increased in lactation, pregnancy, sleep, REM sleep, stress, and sexual stimulation, nipple stimulation. Pathological causes for increase in serum prolactin are the tumors like prolactinoma and craniopharyngioma, systemic causes like chronic renal failure, cirrhosis of liver, and primary hypothyroidism, drugs like phenothiazines, risperidone, then we have cimetidine, then we have the alpha methyl dopa. Then you take the prolactinoma, very commonly observed in middle-aged females of age around 20 to 30 or 20 to 40 years. And prolactinoma, it's a tumor which is originating from lactotroph type of cells from the pituitary gland. And microadenoma is more common than compared to that of the macroadenoma. And what is the difference between these two is micro and macroadenoma, both of them, they'll have clinical manifestations. Endocrine manifestations will be there. But the additional thing in macroadenoma will be mass effect will be there. That mass effect will not be there in microadenoma. And you take in case of the endocrine manifestations in males, infertility and decreased libido. Whereas endocrine manifestations in females, galacturia, amenorrhea, and infertility. When you take mass effect that you have in macroadenoma, that is bitemporal superior quadrantanopia initially, later it is bitemporal hemianopia. And there will be also headache because of raised intracranial pressure. So that will be the mass effect features. Investigations in the workup, investigation of choice will be estimation of serum prolactin levels, early morning fasting state, it should be done. Normal value is 5 to 20. If the value is more than 200, it is prolactinoma. If the value is in between 100 to 200, it is strongly suggestive of prolactinoma. And if the value is less than 100, it might be due to any other cause except for prolactinoma. Then once you know that the value is more than 200, then you need to do MRI of the pituitary to differentiate whether it is micro or macroadenoma. Then coming to the treatment, whatever might be the cause, whether it is microadenoma or macroadenoma, what is that you need to do? You need to give dopamine agonist, that is bromocriptine or cabergoline should be given. And if the patient is refractory to medical management, not responding to medical management, then you need to do transsphenoidal pituitary adenectomy. So this finishes the topic of your the prolactinoma, right? So if you have any doubts, you can ask me. Yes, if you have any doubts, you can just ask me. I'll be very happy to answer your questions. How liver causes, yes, Ananda. So that is what I was discussing, right? What did I tell you? The prolactin, it is metabolized in the liver. It is metabolized in the liver. Now the point is, if there is liver damage, the prolactin will not be increased. The prolactin will not be metabolized. Once the prolactin is not metabolized, the prolactin level increases. It keeps on accumulating. Whatever is being synthesized, it keeps on accumulating, right? So that is the reason why in liver disease, you will have increase in serum prolactin levels. Okay, right. Yeah, any other questions, please? Any other question? Right. So if you don't have any other questions, yes, Dr. Anil, over to you again. Okay, so.
Okay, sure, sir. Thanks for the session, sir.
Right. Okay. So yes, everyone, thank you very much and see you again in the upcoming sessions.
Okay, thank
Good
you.
night.
Thank you, sir.
Right.
Okay, thank you, everyone. So I hope all of you have enjoyed the class. So if you have any queries regarding the class, you can call Viber, you can message in Viber or WhatsApp group for any admission process. If you like to join further class, our regular class will be starting from 6th. Okay, so today is the demo class. So any queries, if you have any queries regarding the class, like the fees structure, so you can directly call or you can Viber, message in Viber. So thank you for the session. I hope all of you have enjoyed the session. केही क्वेरिजहरू छ भने सोद्धा हुन्छ, तपाईँहरूले मलाई पनि सोद्धा हुन्छ रिगार्डिङ द क्लास, रिगार्डिङ द सेड्युल, होइन, त्यसको बारेमा केही तपाईँहरूलाई जान्न मन छ भने सोद्धा हुन्छ है। ठिक छ, त्यसो भए आज विल बी एन्डिङ दिस सेसन है त। सो आजलाई विल बी एन्डिङ दिस सेसन। तपाईँहरूको केही क्वेरी छ भने भाइबरमा हामीलाई मेसेज गर्नु होला है त। अनि फिजिकल क्लास लिन चाहनुहुन्छ भने डाइरेक्टली तपाईँ प्याराडाइज इन्स्टिट्युटमा आएर लिन सक्नुहुन्छ है त। सो थ्याङ्क यू अल फर जोइनिङ द क्लास। गुड नाइट।